Hi, my name is Paula Blackstein-Hirsch, and this webinar is about indicators and targets that are relevant to a quality improvement project. And some of these indicators also go into a quality improvement plan. So let's take a look at this first slide. It includes a family of measures relevant to a quality improvement project. Every project should have at least one outcome measure. These allow us to determine if the goal of the project is actually being achieved. Additionally, every project should have at least one balancing measure, and these kinds of measures allow us to determine if there are any unintended consequences as a result of the interventions or change ideas that are included in the project. And finally, there should be at least one process measure for each change idea. Generally, a quality improvement project includes more than one change idea, so one process measure for each of those change ideas. And what these measures do is allow us to determine the extent to which the change ideas are actually becoming the new way of providing service delivery for clients. Or in other words, how much uptake is there of the new way of doing things by all staff for all client encounters. Let's take a look at the definition and some examples for each of these three types of measures. So outcome measures answer the question, so what? Why are we actually delivering service? And what are we ultimately trying to achieve for clients? The voice of the client is what's really important, meaning these are things that clients care about, and they are also things that funding partners or payers also care about. Some of these measures will be organization-specific, meaning that they're within the control of a single organization, whereas others will be cross-sector types of measures that are contributed to by more than one sector. So let's take a look at a couple of examples. Organization-specific examples might be wait time for service, client satisfaction with care coordination, and you can see that I've attached each of those to a dimension of quality that would be included within the Excellent Care for All Act. So wait times are linked directly to the access dimension, whereas client satisfaction or client experience is linked to the client-centered domain. Outcome measures generally are measures which fit within one of these domains because the domains are client-facing. They're things that clients would care about. Additionally, on this slide is a cross-sector example that fits within the integrated domain, and it's repeat visits to the emergency department. So you can see that for that kind of an indicator, it would be very challenging for one organization to be held solely accountable for an increase or a decrease in that metric. And that's why we put it in the integrated domain, because it takes more than one organization to impact it. And it's definitely an outcome measure. Process measures, on the other hand, provide information about the extent to which a practice or an intervention has been implemented. Or, in other words, it could be viewed as the voice of the process. So let's take a look at a couple of examples. Let's say we had a project where the outcome measure was wait time from time of referral to the time that service is initiated for the client. Let's say that after a diagnostic session and identifying the root cause of the problem, the team decided to implement a change idea that was basically focused on the concept of standard work, that intake staff would prioritize client appointments for assessment within 48 hours of referral. So whenever a referral comes in, intake staff are required to call patients to make an appointment for assessment within 48 hours of that referral. So the process measure basically just measures the extent to which that change idea has in fact been implemented. So a relevant process measure would be the percentage of client calls made to schedule assessments within 48 hours of referral. A second example, let's say we had a project where the outcome measure was client satisfaction with care coordination. And let's assume that the team has come up with a relevant change idea that looks at assigning a care coordinator to clients who are assessed as high risk or those with complex conditions. A relevant process measure would be the percentage of complex clients or clients assessed as complex who are assigned a care coordinator. So you can see that once the change idea is developed, it's very easy to pull or link a process measure to that, just thinking about how would we know that this was fully being uptaken by all staff for all clients. Finally, a balancing measure. So what we said before was this is generally an unintended consequence that could result from implementing the ideas for change. So the first example here is a project where the outcome measure is decreasing the length of service delivery. So assuming that the feeling is that service delivery is going on for too long and that it's actually possible to achieve the same service delivery outcomes in a shorter period of time. So the idea for change might be that if we teach clients self-management, then staff would have to spend less time out in the field providing service. So the idea for change is education on self-management and then cutting back on weeks of service delivery. A balancing measure for that might be the percentage of clients on service who end up having an emergency department visit within 30 days of termination of service delivery. That CTAS 4 or 5 is just basically the lower levels of types of visits that emerge, generally people who walk in, not somebody coming in with a heart attack who would be classified at a CTAS 1 or 2. So percentage of clients on service who had an ED visit within 30 days of stopping that service delivery. The reason that that's a balancing measure is you want to be looking at something as you're implementing the project to ensure that you're not having this unintended consequence of terminating service delivery only to find that clients are bouncing back to the emergency department. The second example is a project where the outcome measure would be overall client experience. The idea for change might be having staff ask clients prior to leaving their home if there's anything else they can do for them on that day. A balancing measure for that might be increased staff perception of workload. Workload is one of those indicators that's very frequently a good balancing measure, because when we do quality improvement and we're implementing different change ideas, we know that we can't add extra work to staff who are already working at 100%. And so if staff perceive an increase in workload as a result of a change in practice, it's highly unlikely that the change will be sustained. So workload is frequently a good balancing measure. So let's take a look at several measures and see how you do at determining whether each is an outcome, a process, or a balancing measure. So let's take a look at the first one. Percentage of clients who are very satisfied with continuity of service delivery. Do you think this is an outcome, a process, or a balancing measure? So if you selected an outcome measure, you were right. The reason is that generally any indicator measuring client experience, you may recall, is an outcome measure. Let's take a look at the next one, the percentage of clients who received an intake call within 24 hours of referral. So if you selected process, you're correct. So you might ask, why is this a process measure? Because it links directly to a change idea related to making intake calls within a new standard of 24 hours of referral. Clients ultimately care about the wait time to service initiation, not all the steps and procedures for getting them to that point. So if the indicator was about their wait time for service, that would be an outcome. But in this case, this measure is linked to the change idea of calling them within 24 hours. Let's take a look at the next one, number of medication errors. Do you think that's an outcome, a process, or a balancing measure? So if you chose outcome, you're correct. This outcome is related to client safety, and it is something that clients would care about. Many people list, this is just an aside, many people list in a quality improvement plan medication reconciliation as an outcome measure. This is a practice required by accreditation for trying to mitigate against medication errors. But it really is a process measure. So medication reconciliation is a process measure that reflects a leading practice ultimately meant to decrease med errors. So medication errors is the outcome or the impact of putting medication reconciliation in place, which is more related to process. Let's take a look at the next one, percentage of clients involved in a team meeting to discuss goals for service. Do you think that's an outcome, a process, or a balancing measure? If you selected process, you're correct. Again, it's related to a new practice of meeting with clients in interdisciplinary teams to discuss a client's goals. Ultimately, if done well, it should impact an effectiveness or client-centered outcome. But this particular measure is a process measure. The next one, percentage of staff who report an increase in workload. Is this an outcome, a process, or a balancing measure? If you chose balancing, you're correct. Generally, anything related to staff workload, you'll recall, will likely be a balancing measure. And as I indicated, in quality improvement, we try to ensure that we're not increasing workload because then we're unlikely to sustain the improvement. The next one, percentage of clients receiving home support who visit the emergency department within 2 weeks of discharge from service. Is this outcome, process, or balancing? So I put 2 check marks on this. Let's go to the far right initially. It's most likely a balancing measure. It's hard to tell without the full context and the details of the project. But because of the way it's worded, i.e. within 2 weeks of discharge, this is likely an unintended consequence of something. If you look at the outcome column, I put that one in brackets. And that's because one could be trying to decrease client visits to the emergency department as an outcome measure for a project. That could actually be the aim of a project. But likely if that was the outcome measure for a project, it wouldn't include the latter part, which is within 2 weeks of discharge from service. Let's look at the next one, percent clients readmitted to hospital. Is that an outcome, a process, or a balancing measure? Again, I've articulated it as either. It could be a balancing measure if it's the unintended consequence of something, but by the same token, we could be trying to decrease readmissions to hospital by, for example, having people go to any variety of community programs, along with the hospital and primary care trying to do a number of things to try to prevent readmission. So this would be likely one of those indicators that would fall within the integrated domain on a scorecard, and it depends on the context and the details of a project whether or not this would be classified as outcome or balancing. Let's take a look at one final one, percentage of clients with an improvement in ADL capability, that's assisted daily living capability. If you chose outcome, you were correct. Functional capability is something that clients do care about, and it is frequently the goal of service. Another way to look at these and sort of try to discern is if you take a look at this measure, number one, as I said, it's something that clients care about, but number two, it can't really be a process measure, or at least it can't be a good process measure, because you really can't tell by looking at that measure what the change ideas might be at the front line. If you could actually tell by the measure what was being done at the front line, it's more likely a process measure. So that's another way of discerning. So let's review these three and then one additional type of measure and talk about what type of data collection is required of each. So for an outcome measure, ideally, we want baseline data so that we can then determine, once we put some changes into place, whether or not the changes are indeed resulting in improvement. We won't really know if we've had an impact unless we have that baseline from before the intervention took place. And generally speaking, the rule of thumb is wanting at least 12 months of data for baseline. That doesn't mean that if we've got 6 months, we shouldn't use it, but ideally we want at least 12 months. Similarly, a balancing measure, although we frame it differently because of its different intent, i.e. to measure unintended consequences, these are generally outcome measures with a different purpose than the project outcome. And so again, we want baseline data. So for example, we can't tell if there's an increase in readmissions to hospital if that was a balancing measure. We can't tell if there's an increase as a result of the project unless we know what the baseline was for clients on our service. Moving to process measures, as I indicated, these are measures that are linked to individual change ideas. And baseline data for these are not required. In fact, it's not usually available because the changes that we make are often new ways of doing things. So we wouldn't have data prior to the project. The only time you might expect to have data is if the change idea is already in place, but the uptake hasn't been as good as you would like. And the improvement goal is actually about trying to improve the uptake. So for example, if the idea was already in place, but there was only 30% uptake in terms of number of staff and or the number of clients being served, and we want to get most processes implemented to 90 to 100%, your goal might be to move it from 30 to 90 or 100%. Another type of measure that we haven't yet talked about are PDSA measures. So once we've identified the change ideas, through quality improvement, we do what's called Plan, Do, Study, Act. And essentially, the purpose is to assess the need for tweaking the change idea to ensure that it's feasible and acceptable before the change idea is fully implemented. And so the kinds of measures that we link to these very small tests of change are generally a mix of quantitative and qualitative, but primarily actually qualitative. So to give you an example, a few PDSA type measures linked to PDSA cycle might be determining whether the new practice, whatever it is adding time or workload. So you might actually time it before and then time the new process and see whether or not it's taking longer to do. You might want to talk to staff after the test and ask whether if it's a new form, for example, whether the form makes sense, whether the content and the format make sense to them, whether there are any changes that they'd like to see if there's anything that actually you realize after the test is missing that you'd like to add. So it's those kinds of things that we measure during a PDSA cycle, and essentially They're assessing the questions of feasibility and acceptability. So we've already covered the information in the first two columns on this slide. We're going to add to this some information about how frequently data should be collected, for how long, and what the data sources might be. So let's go through each of these types of measures. So we already talked about an outcome measure being required, one at least per project, and we've already talked about the fact that ideally we want 12 months of baseline data. These data for outcome measures should be collected on a monthly basis. Quarterly data is too infrequent, so we ideally want at least monthly. The likely data source for outcome data, if it's at all possible, using some routinely collected secondary data source is ideal, because then staff don't have to manually record these data. So if you can get them through routinely collected data, that's ideal. But the key here is wanting to ensure that you can get the data in real time. Having data lag for 3, 4, 5 months is not useful when you're doing quality improvement. How long do we need to collect data and review it for outcome measures? We need these data from baseline, so hopefully a year before the project, right through to the end of the project, and possibly beyond. If this is an important project that's aligned to an organizational priority, it's quite possible that this outcome measure might actually be reviewed on a regular basis at the senior management and/or board level on an organizational scorecard. So it might be that this outcome is being measured beyond the time of the project by others in the organization. Balancing measures. Again, these are linked to a project. Ideally, we've got 12 months of baseline data so that we can tell whether or not there are any unintended consequences. And just like the outcome measure for the project, these should be collected monthly. And again, through routinely collected data, if possible, meaning it's available and it's available in a timely manner. And these data only need to be collected to the end of a project. Once you've completed the project and you see that you hopefully haven't had any unintended consequences, there's no reason to continue collecting this. Process measures, again, one at least for each change idea. Generally, as we just discussed, we don't have baseline data. These data need to be collected at a minimum weekly, and sometimes when we start a project out, we might actually have one data point for each client or for each day, depending on what the metric is. So it really depends, but at maximum, we don't want it any longer than weekly. And the reason for this is around the rules for interpreting change. We need to have data points that are frequent enough that a team knows whether or not the work that they're doing is resulting in improvement. These data are almost always collected manually, either through chart audits, through tick sheets, and we'll look at a few examples of those. And they're collected until the completion of the implementation of a particular change idea. So once a change idea is implemented, and meaning it's being used by all the staff who are supposed to be using it, for all of the clients for whom it's relevant, and it's being maintained at that 90 to 100% level. After that, there can just be a periodic audit to make sure that no one's slipping back to the old way of doing things. And finally, a PDSA measure. There are usually a few of these for each cycle of testing for each change idea. So a change idea, for any particular change idea, you might be doing multiple cycles of testing, and every time you do one of those cycles, you likely have at least a few qualitative, maybe one or two quantitative small measures attached. Definitely we don't have baseline data for these. It's collected with every cycle, and they change by cycle because we have a different purpose for every cycle. It's always manual, and it's collected generally through feedback and interview, sometimes a tick sheet, and it's only done for the duration of that specific PDSA cycle. Hopefully this will be helpful to you to look back at as you're doing quality improvement projects, just to remind yourself about the frequency and the duration for data collection. So let's take a look at a couple of examples of some easy ways to do this manual data collection, sometimes for outcome measures, but always the case for process measures, or almost always the case for process measures. So this would be an example of a tick sheet that would obviously be longer, but that might be kept at intake. So if a process measure is looking at the time from referral to the time of service initiation, an intake clerk would easily have at their disposal the date of referral. They would also know when the time is of service initiation, and then the final column is just a derivation of that. So, that start date minus the referral date gives you the number of days. And this can be on the side of a clerk's desk, can be in a computer on an Excel spreadsheet that's just kept each time someone goes through the process. On the far right, this is actually from a team who is carrying out a quality improvement project in the field, and what they're looking at is ensuring that clients have contact information easily available to get in touch with someone in the organization, generally management, if they have a complaint or a concern. And so this easy tick sheet is something that the PSWs who are going into these assisted living units can keep in their pocket, and when they go into the person's home, they just mark down the date, the client number, and they make sure that the magnet with this contact information is on the fridge, and just basically mark in a yes or a no. Another couple examples, the one on the bottom left is called a safety cross, and this can be used for any kind of critical incident, and essentially the cross includes the days of the month, and this can be up on a wall in a team room. And essentially what happens is, if we use falls as an example, if there's a fall on a particular day, the square is colored in red. I've only colored in the red squares for demonstration purposes, but a number of teams who use this also use green for an incident-free day and yellow for a near miss, meaning it occurred but it didn't result in any harm at all. The chart on the bottom right is what we call a run chart. And this is also for a project in the field where they're looking at volunteers engaging with clients who have dementia. And one of the change ideas, this is for, and actually it shouldn't say days up there at the top of the column, I just realized as I look at this. It's actually the percentage of volunteers who report using profiles to engage clients. And so the volunteers in the background would likely be sending in a weekly data sheet with tick marks. And then someone else would be aggregating that for the various volunteers and saying, of the clients with whom volunteers engaged over that week, how many of those encounters did the volunteer actually use the profile that was provided to them to engage with the client? That percentage is marked on there, and hopefully that increases over time to be 100%. So this slide includes some elements to consider when collecting data. And I'm just going to flip immediately to the example that's on this slide, and we'll go through it together. So the purpose for the measure, and I'm using the same example as the fridge magnet one on the previous slide. So the purpose for the measure is it's a process measure. So in this row, we're including a process measure for change idea about fridge magnets. The indicator name is % of clients posting magnets to the fridge. That's the process measure. The numerator would be the number of clients with magnets for contact information on the fridge, and the denominator would be the number of clients in living unit 1, meaning the living unit 1 is what the project is focused on. So that's the denominator. The data source, these will be manual data collection, as we just saw, and sometimes sampling is applicable. So if there are a lot of clients and you just want to test the idea out on a small percentage of clients first of all, then you might take some sort of a random sampling, or it might even be a purposeful sampling, in which case on this sheet you want to consider and figure out exactly how you're going to do it. Is it going to be every 5th client who's referred? Is it going to be just initially clients of one staff person and then you're going to move to the next? So exactly how are you going to do this? What's the frequency of reporting? Well, remember we said for process measures we want at least weekly. Who will collect it? So this is important because you want to set out a measure and then you want to make sure that someone's accountable for doing it. In this case, it's the PSWs during their regular visits, and they're going to hand in a weekly data sheet to the project team lead, and the project team lead will be pulling that together and putting it on a similar run chart to the slide that we just showed you. So let's move on to target setting for indicators. You'll notice that at the top of this slide, it indicates target setting for outcome indicators. We're going to talk about process measures next, but all of the rules, or all of the guidelines, I should say, on this slide for target setting relate only to outcome indicators. And these actually would be the indicators that are included on the left side of a quality improvement plan. If you're familiar with the Excellent Care for All Act template for a quality improvement plan, and it asks for targets for these indicators. So there isn't a lot of science to this, as much art as science, but it's generally based on either the organization's own experience. So based on setting targets and reviewing results, what is the organization's experience in terms of ability to move, make improvement on outcome measures? What percentage increase or decrease in general have you been able to accomplish? The second bullet refers to if you've got benchmarking available. So if it's possible for you to compare your performance against the performance of others in similar agencies, then you can look at, for example, the top 10th percentile or the top 25th percentile and say your target, you're not there yet, and your target is some point within that. Similarly, the next bullet is best in class. So that means if you have benchmarking, again, information available, it could be within your own jurisdiction or it could be actually internationally, and you pick out the organization that achieves the best result for that particular metric and say that's your goal. Another is theoretical best. So this relates more to safety kinds of indicators where you're looking to get to 0. It could actually relate as well to wait times, where you might try to get to 0 days waiting. Certainly many primary healthcare practices have tried to get to that in terms of advanced access and scheduling for patients. The only approach to setting targets that has been written up anywhere is this half-life process. And essentially it looks at setting a target of a 50% increase or a 50% decrease over time. Generally, this stretch type of target is set over a few years, and then you slowly, year after year, keep setting a target of 50% and you're closing some gap. So let's just highlight an example. Let's say you're at 60% for client's experience and you want to get to 100% in 3 years. In the first year, you'd set a target of a 50% increase, and you'd get halfway between that gap from 60 to 100, so you'd get to 80. The next year, you'd set another 50% increase, and you'd get to 90. And then in that last year, you potentially get to 95%. When you set targets in this way, it does get more challenging to move that metric as you get closer to your target. And so this approach is useful because you're actually, that 50% change is getting smaller in terms of the number of absolute points you need to close the gap on year after year. And then another approach is benchmarks in the literature, and truthfully there are not a whole lot of these. So this is like an evidence-based target, and where those are available, they should definitely be utilized, but we have precious few of those. The key to this is finding a balance between setting an inspirational or aspirational stretch goal and ensuring that staff aren't demoralized by a target that is nowhere near within their reach. So we want to set targets not necessarily that staff are going to be able to achieve and exceed or exceed, but we want to make sure that they can get close. Our real stretch goals are generally set over a few years related to a priority aim. And then as we develop an annual quality improvement plan, we still set aspirational targets, but they're likely not as much of a stretch as your 3-year goal. For process measures, the guidelines on the previous page don't apply because regardless of the process indicator, we should always be striving to achieve 90 to 100%. And this is because, excuse me, these indicators provide information on the extent to which the change ideas have been fully implemented or not. So we want to know that all staff who are intended to take up a new idea or a new way of working, for all clients for whom it's relevant, that's our goal. And if we're only at 30 or 40% at the end of the year, we can't really expect then that the outcome measure that's related to these process measures is going to change. So let's take a look at this family of measures that we've been talking about on the gold standard for displaying data for quality improvement. And the gold standard is either a run chart, which is included on this slide, or what we call a statistical process control chart, which is a bit different. So the top left is an outcome measure, and again I've moved back to one of the projects I talked about earlier where we have volunteers trying to engage in a meaningful way with clients who have dementia. And so the first one is an outcome measure of clients being able to participate in activities with volunteers. That was the team's outcome measure. And you can annotate these charts, and you can see I've done that, showing when the testing of change ideas actually occurred. So all of the data up until this point is baseline data. And you can see that on this particular chart, we only had 11 months of baseline data, which is good enough. The chart on the top right is one for a balancing measure. And so clearly if the goal was to engage these clients in a meaningful way, an unintended consequence would have been them being more agitated after the visit than before the visit. And so clearly the target here would be 0. And so you can see again that you can annotate where the PDSA testing starts. And we can see on this particular one that once PDSA testing started, there actually was a decline being reported. I didn't neglected to mention that on the outcome measure as well on the charts, we always put the target. So we can see where the baseline is, where the target is, and then we start inputting data and seeing month over month how we're doing on getting close to, if not exceeding, the target. On the balancing measure, you'll see both on the outcome and the balancing measure that we've recorded these data on a monthly basis. On the bottom half are two process measures. So the first one is the percentage of volunteers who report using profiles to engage clients. So there are these profiles that are being developed that give background information to help the volunteers know a bit more about these individuals and what they like, and so giving them tips on how to engage better with them. And we can see that this process measure was on a steady incline, and it took a dip, and it's useful for the staff then to reflect on why did that happen, and they realized that actually that was the week of March break. And so the volunteers weren't necessarily being given the profiles, so the team needs to figure out a way of ensuring that these are still provided even when the person responsible is away on holiday. You can see that these data are being reported out on a weekly basis. And similarly, the same kind of chart for process measure on the right. New assessments that are being completed with a new tool that was devised for this project. And you can see that the goal for both of these is 90 to 100%. So let's turn it over to you. I'd like you to look at these indicators and targets, options for targets, and determine which of the following targets are appropriate for the indicator that's listed here. I'll give you about 30 or 45 seconds to think about it and select one. If you chose 95%, number 3, then you're correct. This particular indicator or measure is a process measure. Clients don't care about teach back per se, but it is an effective method for teaching self-management. So it's one of those change ideas that were put into place. This is an indicator that helps the team to determine how well that change idea is being implemented. And so for a process measure, we want a target of 90 to 100%. So none of the other choices here are relevant. Let's take a look at another one. This indicator is number of medication errors resulting in harm. Which of these targets is an appropriate target? So remember, the first thing to do is to say, what kind of an indicator is this? Is it an outcome, a process, or balancing measure? And then what might be an appropriate target based on that? I'll give you another 30 seconds. So either number 1 or number 2 would have been correct answers. This is an outcome measure, medication errors resulting in harm. For an outcome measure, we use that page that had different guidelines on it. If the target was 0%, it would be theoretical best. If it was 5%, that might be a stretch goal based on where the organization was at in terms of baseline. So if they were at a baseline of 20% or even 10 or 15%, it depends on how many errors that actually reflects, then 5% might indeed be an aspirational target. 90% clearly isn't the right answer because it's moving in the wrong direction. And 4, I guess, could have been an answer. Let's take a look at the next one. Take a look at this indicator, percent increase in time required to complete intake. Is this an outcome, a process, or a balancing measure? And then determine which target is appropriate. So if you chose 0%, you're correct. This is a balancing measure. So increase in time required. Remember, we don't want to add workload. We don't want to add the amount of time that a process takes. So this is an unintended consequence of some intervention. And out of all of these targets, we would definitely want to ensure that we're not adding any time. In fact, we'd like to see it be less time. So we'd like a percentage decrease, ideally, but we definitely don't want to be adding anything. So just to summarize some of the key points made during this webinar, we want at least one outcome measure attached to each project. It allows us to determine if the goal of the project is in fact being achieved. And there are guidelines that help us to set targets for these measures. We want at least one balancing measure. This allows us to determine if there are any unintended consequences resulting from the project. And generally the target should be 0 or as low as possible, since it's an outcome that's not desirable. We want at least one process measure for each change idea. These remember that they allow us to determine the extent to which the change idea is becoming the new way of doing things for all staff, for all clients, and the target should always be 90 to 100%. The data for these measures come from either routinely collected sources for outcome and sometimes for balancing measures as well. Process measure data generally require manual data collection, and the goal there is to develop simple real-time methods for data collection to decrease staff burden. And a key message that I don't think I've articulated during the webinar is we should never skip measurement. It's easy to do, but without it, we will never know if the changes that we're making are actually resulting in improvement. So good luck with developing measures for your project and displaying data in an appropriate way over time.